As you might know, there's a correlation between high levels of blood pressure and the occurrence of intracerebral hemorrhage after thrombolysis. So what most guidelines advocate is to lower the blood pressure with IV antihypertensive agents. However, this was never proven to be the right strategy. And whereas this is adopted in most parts of the world, in the Netherlands, there's some practice variability, with about 70% having the active blood pressure lowering strategy, which means that they use IV antihypertensive agents, as in the rest of the world, which is the prevailing practice. However, there are also centers that adhere to a protocol where they do not lower the blood pressure actively, but they just wait until the blood pressure drops spontaneously below the guideline thresholds and only then administer IVT. So against this background, we thought it was the perfect background to investigate this problem. And in practice, it's not a very common finding, but about 1 in 10 patients that we see with who are otherwise eligible for IVT have blood pressure levels above the guideline thresholds. So it accounts for 1 in 10 patients possibly eligible for IVT. The truth was an observational multi-center cluster designed study in which there were centers adhering to a protocol with an active blood pressure lowering strategy, which were 27 centers, whereas there were 10 centers with a no active blood pressure lowering protocol. And we had a projected sample size of 1,235 patients, but we had to stop in 2022 because of a declining inclusion rate and because it was attributed to the COVID pandemic. But at that moment we already had included 1,052 patients. Obviously, since this was not a randomized trial, we pre-specified in the protocol paper that we would adjust for certain imbalances on baseline variables. And we would also adjust for variables that we previously thought important to adjust for, such as age, sex, and also stroke severity on baseline. And also we had to factor in a random factor because of the cluster design. So all the analyses were adjusted for these factors. At baseline, there were some differences for hypercholesterolemia, the use of antiplatelets, and a previous stroke or TIA, which was a bit more common in the patients from active blood pressure lowering centers. So the primary analysis was adjusted for that. And the analysis was on functional outcomes scored with the modified ranking score, which was assessed blindly by certified research nurses 3 months after inclusion. So the primary outcome was an ordinal shift on the modified ranking score. As I said, the baseline characteristics were well balanced, except for the 3 variables that I mentioned earlier. And what we saw, and this was somewhat contrary to our expectations, that there was a shift towards worse functional outcome associated with active blood pressure lowering, which is the prevailing practice worldwide. This shift, however, was not statistically significant after we performed the ordinal regression analysis. In addition, we did also analysis with cutoffs of the MRS score that were different to have binary outcomes as well, and they showed very consistent results also with the direction of the point estimate in the same direction, with worse outcome associated with active blood pressure lowering. So all these results were consistent, however, not statistically significant. Well, I think it's very important that we realize that the blood pressure thresholds are derived from the original trials investigating the clinical benefit of IVT. In these trials, it was specifically mentioned that the blood pressure could not be lowered with the use of IV antihypertensive agents because of concerns that a rapid decline in blood pressure could compromise cerebral perfusion. So what we are doing in the world right now is that we do actively lower the blood pressure, and we do this very fast because we want to be fast in our treatment with IV thrombolytics. However, I think we should make a sort of shift, which is also in line with the other studies. One of the studies presented here with blood pressure lowering already in the ambulance, the INTERACT-4, which showed also a harmful effect of blood pressure lowering in the acute phase. So I think we should go back to the drawing table, and we should consider whether we should treat these patients actively with IV antihypertensive agents, at least until randomized data become available that this is safe and efficacious.